Hello, my name is Carolina Varela. I am a physician at the Quality of Care Unit of the Hospital Universitario 12 de Octubre in Madrid, Spain. I am as well member of two scientific societies, the Spanish Society and the Madrileñan Association of Quality of Care. Thanks for watching. It is a pleasure for me to introduce you this work titled Value-Based Healthcare Implementation Framework from Practice to Theory, Barriers and Facilitators. There is growing interest in translating value-based healthcare into practice to increase the sustainability of the healthcare systems. At the Quality of Care Unit, we have been working since 2018 with implementing value-based healthcare and changing the institution's paradigm toward measuring outcomes and value for patients. Our pilots for the moment have been breast and lung cancer within the boys community, inflammatory bowel disease within the improved community, age-related macular degeneration within the itch on the eye community, and COVID-19. After these 2 years of pandemic, the institution has analyzed the first year data. These results will help evaluate the impact and efficiency of the new technologies. We have as well analyzed the barriers and facilitators from the implementation. We want to share this with you all, so our good decisions and our pitfalls can be used as a guide for other institutions that wish to direct their mission to value-based healthcare innovations. Due to the complexity of the implementation, we have to use several methods explained in detail in a specific publication or technical reports. We have used a modified Delphi study with 2 rounds with a consensus criteria where the consensus criteria was that there should be a median equal to or greater than 4 and a relative interquartile range equal to or less than 25%. We have used as well semi-structured personal interviews where the consensus criteria was the information saturation during the interview. And we have used collation of the personal experience of implementation working with a team of professionals of each of the processes and the discussion groups with patients and professionals. For the discussion groups, the consensus criteria was the information saturation. As for the cohort descriptive data, we used descriptive observational studies were performed in COVID-19 patients and breast and lung cancer. We end up with 869 COVID patients, follow-up at least 3 to 9 months, and a cohort of 226 patients follow-up 1 year. They were patients over 16 years of age and that have been discharged from the hospital. The cohort of the breast cancer cohort and the lung cancer cohort patients gave us with a complete follow-up of 1 year of PROM and clinical indicators, an N of 42 in breast cancer and 36 in lung cancer. We have recorded as well socio-demographic variables in these studies, such as age and sex, and were analyzed during the studies. And we also analyzed the loss and recovery of health-related quality of life using validated PROMs or quality of life questionnaires. Absolute percentage and frequencies were used to represent categorical or qualitative variables, and the mean and standard deviation were used for the quantitative variables. The chi-square test and the student's t-test were used to analyze differences between variables with 2 categories or the analysis of a variance statistical model ANOVA for variables with more than 2 categories. A statistical significant difference was considered with values of p minor to 0.05 and a 95% confidence interval for mean difference that did not include 0. The analysis was performed with the SPSS version 26 statistical package. As per our experience and regarding the conceptual framework of the implementation science backing up the value-based healthcare innovation, it is important to understand value-based healthcare as a real paradigm change affecting the whole core of the organization and that it will change the daily work, the continuous improvement circles, and the service payment methods, and therefore it will drastically change the managerial decisions. That means important cultural and technological adaptations. To do so, we recommend to plan the implementation in three main phases, even if for the moment we plan it in only one healthcare process. The first and perhaps more important phase is the pre-implementation, represented up in the figure by blue symbols. During this time, which should be at least of 1 to 3 months, the institution has to understand if they are value-oriented, even if they still have not measured value or it was not included in their current mission. They should ask themselves, is it included in the vision of the institution? If that is the case, as it happened to us, then the institution has to assume an amount of implementation costs. So, is the institution willing to pay the price? If that is so, then the bricks are laid for developing an innovation process during the following months. Thus, the institution has established the strategic planning. The second phase, represented in yellow in the figure up, the second phase, which is longer, the longer one and contains 3 key steps for sustainability of the innovation in the future, it is the implementation phase, and it is the one we want to detail here more. In agreement with the literature in implementation science, we notice that this phase has a duration of 18 to 24 months, depending on the complexity of the process. Consider, it can be divided in 5 sequential steps. This division is artificial and is just only made with teaching intentions. So the first part would be communication. We explain to the working group first and the whole institution later on, including patients and other stakeholders, the decision to lean toward value-based healthcare. We offer information and success cases from other institutions, if it's the case, from our own institution. Then it comes the appraisal. Here we make an effort to convince and motivate the working group on working on value-based healthcare. Appraisal is paramount for the success of the implementation. Then it comes preparation. This is the more technical part of the implementation. Here we prepare the institution and its several tools to be able to work in value-based healthcare paradigm. This includes hard changes such as technological tools interoperable with the health information system, or soft changes in the way people work on the institution. And then it comes piloting. At the piloting, we begin to use the novel set of behaviors, routines, and ways of working within the setting, which is the innovation. It is important to detect problems and barriers for including it in the daily work. We need to extend this step up to obtain a representative sample of the intended patient population so we can assess the benefits of the proposed new technology. And then in green comes the post-implementation. Once we have decided that the innovation is useful for our patients and our institution, then we carry out the post-implementation phase, which is the last one, and it allows the innovation to be real once the technology is assessed as better than the previous process and it's adopted in the daily work and become the routinely workflow. At that phase, the methodological support would diminish as much as possible, leaving or eliminate reduce to helping in data and indicator analysis as in any other process of the institution. Thus, the methodological resources can be derived toward another process beginning the innovation. As we see at the bottom of the figure, the flowchart represents details at a detailed implementation phase. This phase is divided in steps up to the beginning and is represented up to the beginning of the post-implementation phase. So focusing in the implementation process represented in the flowchart, we see the arrival of the information projects basically through 4 entries: the managerial department, the hospital services, a consortium as it can be Voice, Improve, H on the MySpen, or H2O, or even through a research project. But it could be impossible to respond to all the petitions of implementation in a given moment of time, so the institution should develop tools for prioritizing projects. We have presented another poster showing the tools we have developed at the Hospital Universitario 12 de Octubre for analyzing feasibility, complexity, and resource allocation. Once the decision is taken as to continue with the project, there is need for selecting the leadership and coordination. As leader, it's advisable to have one managerial leader and overall one clinical leader with natural leadership over his or her peers in the process. As for coordination in our institution, as in many others, was decided that the quality of care professionals were the coordinators of this project. In this case, that person was me. Then the technical work begins with the process analysis. This helps identify who, when, and where the record data. It helps identify who, when, and where the data is recorded. It's done for the clinician reported outcomes, for the patient reported outcomes, and for the patient reported experience, as signaled in the figure. It helps understand the information flow and the possibility of automatic extraction of the information for future data exploitation. Here we have presented the patient-reported outcome and the experience recording. Even if experience was not initially included as part of the value-based healthcare shift, it has shown to be important for process improvement and patient inclusion in the process. So we have work in parallel in patient experience and value-based healthcare in all the processes we are working with. Once we know our process flow, we need to adapt the data, structuring and standardizing data, and the tools for recording and extraction. That means several changes, including labeling patients within the cohort, have usable tools for introducing data in the database, including patient-reported data, which is not usually allowed in the electronic health records. As benchmark is an important objective of value-based healthcare, we need to prepare the information to make it happen. So we need to normalize and standardize the data in a shareable manner and determine the visualization of the information in dashboard usable for clinical practice and benchmark. And adapting all the data and tools include the costs that often are not even considered per patient. After data and tools are adopted, as I was saying, after data and tools are adapted, people has appraised the change and understand the new available tools, we can begin the outcome measuring for personalized clinical decisions, measuring value for patients, for healthcare continuous improvement via benchmark, and for health technology assessment that will give us the clue as if it should or should not stay in the daily work. So, as a mere act of showing and evidence of our implementation, we bring here the first results sent to VOICE, our best practice community of hospitals for benchmarking. We show here not all the cohort, but the one complying with the inclusion criteria and without any exclusion criteria for the first benchmark within the community. We were able to send 42 breast cancer patients with all the follow-up complete up to 6 months after diagnosis. It is approximately the 20 to 25% of the global cohort for these 6 months of the hospital. The demographic characteristics and the cancer characterization was well within parameters of the usual breast cancer demographics and tumor types. One of the most strict inclusion criteria was having the prom completed up to 6 months, and we were able to do so only in these 42 patients. The reasons are several, but the main is that in Spain currently there are problems of lack of professionals due to limited resources and to the impossibility of hiring professionals. This has important repercussions on their nursing work and the need time for implementing PROM in the daily work during the implementation phase. Beta test of the tools and education of the professionals and patients on the need to answer and check this questionnaire as much as on how to use the ICT tools. We have to train the nurses, and in several occasions, once trained, they left the institution and there was no substitute when the main nurse was on holidays or on kids caring leave. Even though here we show you the evolution of the quality of life in these 6 months on the patient with breast cancer. As the bottom part of the slide, we wanted to show the fact that we have been measuring costs per patient in breast cancer to close the circle of value for patient calculation. We calculated the cost by professional act and inputting the cost according with the salary and resources used in each of these acts. And finally, and sorry for making this too long, we present here the barriers and facilitators in this implementation process. I will not go into detail. You have this presentation and the poster and the abstract sent and the article published talking about that in the link showed in the video description, if you were so kind as to show interest for our work. Just comment a couple of barriers and facilitators that have been particularly important to us. The status quo bias means that resistance to change completely justified if we understand that we are talking people's life here and mistakes can produce important health problems for the patients. However, there is a potent facilitator, which is the peer communication, the peers. Identify the professionals that have a profile of early adopters of innovation and empower them as the leaders of the project. Also present the team with a case of success, if possible, from the institution. Also, it's important to fight the unconscious ignorance, which means that the less you know about an issue, the more sure you are about things and the more simple it seems to you. Failing to understand the challenge of the implementation is a recipe for failure of this and probably any other innovation proposed in the future. Several administrative and normative barriers can be sorted out before happening. The value-based healthcare innovation is a healthcare process, and it's not really a research project. They are focused on continuous improvement and thus mostly have no need for ethics committee evaluation. In fact, they don't modify at all the healthcare. However, it is advisable to do so, to check with the ethics committee for the secondary use of the data derived from the new health information system put in place for the innovation. As well, the participation of the patients can generate concerns about the personal data protection. These projects respect the confidentiality and the patients have in fact the right to participate actively in their health care process and in their health system in most of the countries checked. We decide as well to ensure data storage physically inside the institution. All information going out are anonymized or pseudo-anonymized. Well, thanks for watching and thanks for the interest. We are at your service. I leave there my contact information. If you feel like giving feedback or asking questions, you can either write to me or leave a comment on the video. There are several people related to this work that would be very happy to answer your questions, including me, of course. In the video description, you have a link with the PDF of the poster, the abstract sent to the meeting, and an article regarding this issue. We do appreciate your interest, and remember, ultimately, the secret of quality is love, as Abedis Donamedian used to say. Thank you very much. Have a lovely day. Bye.